I want to sincerely thank you all for spending your Saturday with us. This group has done an amazing job of putting together a course for you. We've had great food, beautiful view of the mountains, and some beverages. So we're really, really pleased that you could join us. And we really do like to share the hospitality of this building because it is a fabulous gift to the university. We now have a little bit of time for a kind of a fun session. This is really designed more for an interaction with the group, and we hope that you'll feel very comfortable making your feelings known. We have two expert debaters here to talk about updates in colorectal cancer screening, and we have a specific format for the debate. I don't know if it's here or not, so let me see. What's that? Yeah. Okay, so Blake Jones, who you met before, the course director, is going to discuss the choosing a colon cancer screening test. Colonoscopy is better than the rest. And our own Swati Patel is going to take the con opinion that the best test is the test that gets done. So as you're thinking about this, I think it's fair to think about colon cancer screening, not just the results of an individual test, but as the process and how important it is. These are disclosures for the slide, for the talk today, the same ones as before. And here's the format. So we're going to, after my little introduction here, we're going to have the pro discussion, colonoscopy is better than the rest, by Blake. Then we're going to have a cross-examination question. And I've neglected to mention that we're going to do an audience poll for this debate. And we're going to do the poll 4 times. So you're going to do it at the very beginning. And the idea is to see whether the debaters have actually swayed the population's opinion of the poll. So the first time you're going to do the poll right after this, then we're going to have Blake, then we're going to do the cross-examination and questions from the audience. Then we're going to do the poll the second time, and then we're going to do the con, which is the best test is the one that gets done. Then we're going to have the cross-examination and questions and audience poll number 3. And then we'll have a little bit of time for them to go back and forth, and then we'll have an open forum. Fair enough? All right, let's go ahead. Can we initiate the poll? So what we'd like you to select, yes or no, colonoscopy is the best colorectal cancer screening test in the United States. Uh-oh. All right, I'm going to turn this over to Blake and let him just start the discussion.
All right, well, it looks like I have a head start. Though I do have a head start, I had the advantage also as being a course director and therefore getting to choose my opponent. And so I asked Swati to do this, and she generously agreed. And then shortly after, she informed me that she was like the debate president in her high school and college and all these type of things. So I say that not to handicap myself, but mostly just you need to hold Swati to a much higher standard than me. All right. So in my portion of the debate, I'm going to make 3 main arguments. Number 1, I'm going to show that colonoscopy works. Number 2, I'm going to make the argument that not only does colonoscopy work, but it probably works better than we even realize, and especially with recent advancements, is only going to work better and better into the near future. And then finally, we'll talk about where stool-based screening falls short. So let's start with the circumstantial evidence, right? So these are time trend analyses showing the incidence and mortality rates of colorectal cancer over the last several decades. And we can thankfully see a pretty steady decline over those decades. But what we specifically notice is a sharp drop right around the year 2000, which coincidentally is when Medicare started covering colonoscopy for colorectal cancer screening. And then this other graph over here just shows the inverse relationship between the uptake of colonoscopy for screening and the decrease in the incidence of colorectal cancer over time. So circumstantial evidence, take for it what you will. To me, no, not altogether unconvincing. All right, but what about the other evidence? So we have large population case control studies, observational studies, including thousands of patients that show a benefit to colonoscopy for colorectal cancer screening. And that is it showed a big benefit. So up to a 3/4 to 80 to 90% reduction in incidence and 2/3 or greater reduction in colorectal cancer mortality. Now you'll probably say, observational studies, they're great. they're what we have right now for colonoscopy and colorectal cancer, but they're prone to bias. And I agree that the benefits of colonoscopy are probably exaggerated by these studies. So what about RCT data? Well, we don't have RCT data for colonoscopy, but we do have RCT data for flexible sigmoidoscopy. And I don't think it takes a genius to extrapolate the benefits of an exam that visualizes half the colon to an exam that visualizes the whole colon. And specifically, if you look at the data in flexible sigmoidoscopy, shows a 25% reduction in incidence and a third reduction in mortality with screening versus no screening. But if you isolate the benefit to just left-sided cancer, so the portion of the colon that flexible sigmoidoscopy is actually viewing, the benefit goes up to about a 50% reduction in incidence mortality. Therefore, if you extrapolate flex sig to colonoscopy, where you're looking at the whole colon, it's not unreasonable to assume maybe a 50% reduction in incidence mortality with colonoscopy. We don't have that data yet. All right. Now, some of you are probably saying, well, we do have RCT data for colonoscopy for screening for colorectal cancer, right? So end of last year, New England Journal of Medicine, this was all over the newspapers and the media, the Nordic trial. Very disappointing results in the benefit of colonoscopy for prevention against both incidence and mortality. Showed a very moderate reduction in incidence and no benefit in mortality for screening with colonoscopy for colorectal cancer. So, I mean, I'll leave it to all the editorials that were published, you know, from all of our colleagues and experts in the field to try to I guess, rebut the main points that were made in the media, not necessarily in the article itself. But I do want to highlight a few things from this study. So first off, the study really was not assessing the benefits of screening colonoscopy for colorectal cancer incidence and death. It was assessing the benefits of an invitation to undergo colonoscopy for screening for colorectal cancer. Because only about 40%, slightly more, actually underwent colonoscopy within the intervention arm, the colonoscopy arm. In the United States, we know that we've achieved at least 60% and probably greater, closer to 70% of patients undergoing colonoscopy for screening, and it's higher in even some centers than that. So imagine we had a near 20% reduction in incidence of colonoscopy with just 40% of patients actually getting a colonoscopy. And if you did the per protocol analysis that looked at just patients who got the colonoscopy, there was a 30% or more reduction in incidence and a 50% reduction in mortality, which coincidentally aligns with what we see with flexible sigmoid, the data in flex sig. So furthermore, what else was wrong with this study? Well, it wasn't powered to detect a mortality difference. It takes a really long time for colon cancer to form. And this was a 10-year analysis of a study that was powered to really detect a difference at 15 years. So it's not surprising that there was no difference at 10 years, because you can see that the rate of colon cancer in the usual care group was really small, 0.3. If you can extrapolate and predict what's going to happen with these time trends as you go out to 15 years, it's not hard to predict that the benefit of colonoscopy is going to increase and eventually become statistically significant. The degree, we don't know, and it depends obviously on the number of patients who actually undergo colonoscopy. And then finally, I'll make the point that this study demonstrates that colonoscopy is safe, right? There were 12,000 patients in the study who underwent a colonoscopy. There were 0 perforations, 0 deaths. There was a 0.13% rate of significant bleeding. All of that was managed endoscopically. So this study not only suggests, and like we will show later on, that colonoscopy is beneficial, but it also shows that colonoscopy is quite safe, one of the perceived limitations of an invasive test like colonoscopy. All right, so moving on. I'm not only going to make the argument that colonoscopy works, but I'm going to make the argument that it probably works better than we even realize. So this is a study out of Poland, so not United States cohort, but not coincidentally some of the same authors from the Nordic trial. They looked at the benefits of a one-time negative screening colonoscopy, so those are patients who don't have polyps or anything like that. But this is what they showed. So not only did they show, obviously, that these patients were low risk for colon cancer, there was a 72% reduction in incidence, 81% reduction in mortality related to colon cancer in the patients who had a negative screening colonoscopy. But in patients who underwent a high quality exam, so for them, high quality was cecal intubation, adequate prep, and an ADR of the provider performing the exam of greater than 20%, which is below the threshold that we've established in the United States, which is in of itself low. That benefit of that one negative screening colonoscopy lasted not just for 10 years, which is the interval we use in this country, but for over 17 years. that suggests that colonoscopy, even maybe once, has the ability, if it's negative, to protect you against colon cancer incidence and mortality for even 2 decades or more. All right, so I will admit that colonoscopy is not perfect. Post-colonoscopy colorectal cancers do occur. They are the vast minority of colorectal cancers that we see. And they're primarily due to the inadequacy of the exam. So either the cecal intubation was not, there was no cecal intubation, the prep was inadequate, or the provider just missed a lesion. So the good news is those are factors within our control, right? If patients, we didn't get cecal intubation, we can bring the patient back. If the prep wasn't good enough, we can bring the patient back. But the biggest problem with colonoscopy is the inter-provider variability. It's very operator dependent in terms of its ability to provide an impact and reduce colorectal cancer incidence and outcomes. And we see that because we know that the adenoma detection rate, which is the gold standard quality metric for screening colonoscopy, is inversely proportional to post-colonoscopy colorectal cancer. But there's wide variability in ADR among providers. But now I'd argue for the first time with the advent of computer-aided diagnosis and AI technology, we have the ability to bring low-performing providers up so that we all are achieving a baseline level of performance that truly leads to added value for screening colonoscopy. Something we really haven't had. I mean, we've had, feedback, we've had remediation videos, things like that. But until now, we actually have a bedside tool that allows us to, and I think within the pre-market and post-market literature that we've seen, may not improve those who are already achieving really high ADRs, but can help bring low-performing providers up to a certain level, therefore improving the benefits of colonoscopy even further. And not only can AI improve the detection ability within the colonoscopy, but it has the ability to reduce the cost, right? Because not only do we have polyp recognition technology, but we have polyp discrimination technology, which one might reduce the resection of non-neoplastics and completely benign polyps, lowering potential complication rates, but also reduce the cost of a colonoscopy, because with this you don't need pathology. All right, and now finally to the crux of the issue, relative to colonoscopy, where stool-based testing falls short. So this data is a little bit old, but within the last decade. So what's important about a good screening test? A good screening test should have a high sensitivity. You want a low false negative rate because you don't want a bunch of patients having a normal test who actually have the disease. So we can quibble over whether or not, what an adequate sensitivity is based on the cost and, relative invasiveness and risk of the procedure. But what we probably can't quibble about are the performance characteristics of FIT or other stool-based testing for not cancer, but advanced adenomas. Or in much of our clinical practice, they're treated the same as cancer in terms of family history and your perceived risk. And we can see here that across the board, stool-based testing performs pretty poorly. The best is for FIT DNA, which is Cologuard, and that's up to 40%. But if you notice here, that's with doing FIT DNA every year. And this explains probably why most of the literature and the studies that report the benefit of non-colonoscopy or stool-based testing show a very modest benefit in mortality, but show none or almost no benefit in colon cancer incidence. And that's, I think points to one of the unique opportunities of colonoscopy that really doesn't exist anywhere in cancer screening. And that's the ability to not only detect cancer at early stage where it's treatable and curable and introduce mortality, but to prevent cancer from ever forming through the resection of pre-neoplastic polyps. And that opportunity is limited with stool-based testing just because of the poor sensitivity of the tests to recognize those lesions. All right, and then furthermore, so I think the best argument against colonoscopy for screening, especially on the population health level, is that it doesn't get done. And to some extent, that's true. But this was a recent study, actually published last month, that looked at a trial of a facilitated screening for colorectal cancer across 3 diverse large health centers in the United States. And this is what they showed. So a lot of the studies that compare FIT or show the benefit of FIT in terms of getting people screened, look at these programmatic approaches where you mail FIT out. And yes, you do get more people screened. But the truth about FIT is that another stool-based testing is that you have to do it year after year after year to get the same durability and benefit you get from colonoscopy. And what they showed was that in this facilitated screening program, at 4 years, less than 40% of patients had actually gotten 4 consecutive fits, whereas 83% of the patients had gotten just a colonoscopy within the first year of being enrolled in this trial. And to get comparable rates of screening completion success, they had to allow for significant crossover in the FOBT arm, so that, a quarter of these patients actually underwent colonoscopy. Some of them had only gotten 2, with 1 or 3 stool tests. 6% of them almost didn't get a follow-up colonoscopy with a positive fit. And even then, they didn't reach the rate of screening success that they had in the colonoscopy arm, where there were additional 5% or so of patients who ended up getting a colonoscopy in the subsequent 4 years. And then finally, I make the point that stool-based testing is a 2-step test, right? If you have a positive test, you need to get a colonoscopy to get the benefit from the screening, because a negative test likely indicates, for within the confines of the limitations of the test characteristics, that patient doesn't have colon cancer. To actually benefit patients who have positive tests and detect their cancers early, or detect their preneoplastic lesions that you can remove before they become cancer, you need to get those patients in for colonoscopy. And in these large scale health systems that try to deploy programmatic fit-based screening programs, there's pretty clear evidence that it's really hard to do that. And up to 50% of patients don't get colonoscopy or don't get timely colonoscopy. So therefore, I leave you with answering the question, is it really worth the upfront effort of getting patients to do fit so that you improve your screening metrics and you get more people screened, when the people who then are identified to be high risk don't always get the actual care that they need, when this study shows that if you do the effort up front and get people to colonoscopy, they do seem to do it, and therefore actually get the benefit of the screening that they're intended to get. That's all I have. Thank you.
Before we start, we're going to take Blake's argument in consideration and repeat the poll. So if you could please select your choice again. Excellent. All right. Now it gives me great pleasure to introduce Swati Patel, probably the expert in colon cancer at our institution, coming to us today in her very delightful mode of talking about colon cancer screening.
All those graphs and tables and figures, anybody else get Ross Perot vibes? No, just me? It's not the ears. It's not the ears, really the figures. No. I do have my work cut out for me. What Dr. Jones didn't share is that I recognized that he designed the debate, and I let him choose his position, and I knew I'd be coming in as the underdog. So thanks everyone for being here. It's a delight. Congratulations to the course directors. This is an outstanding conference, and I'm amazed that you all have stuck to it to hang out with us. And I brought my phone up here so that I can participate in voting, okay? All right. So before I start my presentation, I get the opportunity to ask Dr. Jones one question. Okay, this is kind of a cross-examination question, so make sure your mic is working. Dr. Jones, 45-year-old woman, marathoner, lives up in Boulder, vegan. She's coming to you for a second opinion because she heard you're an expert in colorectal cancer screening. Her doctor ordered a colonoscopy, and she doesn't have any family history of colon cancer. She has no symptoms, and she said she'll absolutely do it if she has to, but she really would prefer a less invasive test. What would you recommend to her?
Does she like collecting her poop at home every year, year after year for 10 years?
She's not available to answer that question. So
I'd tell her that she's likely to be low risk for colon cancer. In a country with the resources that we have in the United States, she has options. She could choose to get stool-based testing, Cologuard or FIT, or multi-target stool DNA, I should say, or FIT. Or she could choose a colonoscopy. The test characteristics of colonoscopy are better, but If you want to avoid an invasive procedure, then you could choose stool-based testing.
Okay. Well, that's a great answer. I think it's a good advice to our patient and sort of contextualizes the conversation we're going to have today. So I'm going to argue the position that, in fact, the best colorectal cancer screening test is the one that gets done. I'm not saying excluding colonoscopy. I'm saying overall, the best one is the one that actually patients will get done. These are my disclosures, which we've shared before, but I do actually have to also disclose that I'm a colonoscopist, and many of you have shared an endoscopy room with me and know that that's what I'm passionate about. But the reality is I stand by my position at this podium and even in the endo room today. So what I'm not going to do is tug on your allegiances of having scoped with me, our relationships that we've had over the years, to sway your vote. And in fact, we know it hasn't, right? Because the votes have already come in. Everyone in this room overwhelmingly favors colonoscopy. What I'm also not going to do is bore you with study after study after study that shows that non-colonoscopy screening modalities decrease death from colon cancer, decrease the number of cancers that our society deals with. What I am going to do is look at this very simple question that you have been given the responsibility to weigh and vote on. And that is that colonoscopy is the best colorectal cancer screening test in the United States. So let's break this down a little bit. What do we actually mean by screening tests? What are screening tests supposed to accomplish? Well, as Dr. Jones really nicely explained, we are in a very lucky position with colorectal cancer because we know that colon cancers can progress over time from normal tissue to precancerous polyp, early stage cancer to invasive distant disease. So we know that those that are diagnosed with colon cancer, even at early stages, it's a substantial burden to them. Not only the burdens of going through treatment, the side effects of chemotherapy, the surgical risks, the hospitalizations, the cost, but even if they survive that cancer, they oftentimes over their lifetimes deal with long-term side effects and problems and financial toxicity because of that diagnosis. And unfortunately, for cancers diagnosed at later stages, only about 13% actually survive that. So we are contending with a disease that is very common in our society and kills people. The beauty is that if we're able to find these cancers at early stages, at the precancer stages where somebody like Dr. Hamad can remove a large polyp before it turns into cancer, or even at early stages where a patient needs surgery, we know that we can actually completely prevent the significant morbidity and mortality associated with colorectal cancer. So when we think about this question that you've been asked to vote on, the answer to this question, when you think about this, is not what's the best colonoscopy or what's the best colorectal cancer screening test for you or your spouse or your kid. It's what is the best colorectal cancer screening test for the United States. So with all of this, we really need to think about what is the modality that we can employ as a society to really confer the benefit of prevention and early detection in all citizens in the United States. Dr. Jones really waxed poetic on colonoscopy. And in fact, it's not news to this audience. Many of us are involved with colonoscopy during our day jobs. But when we think about colonoscopy, indeed, it is very effective when you look at it in a silo. It is the most common colorectal cancer screening test performed in the United States. Of all the colorectal cancer screening tests done, over 90% are actually colonoscopy in the US. In addition, he also told you, look, colonoscopy is far superior to stool-based tests, other modalities, because it can actually detect disease along the entire spectrum. Precancer polyp, early stage disease, all the way to invasive disease. He also showed you these beautiful test characteristics where colonoscopy, if a patient has cancer, it will detect the cancer in over 99% of cases. And even most impressive, it can prevent cancer by detection and removal of advanced colorectal polyps. So we know from his presentation, it's the most common colorectal cancer screening test performed in the United States. It can detect disease along the entire spectrum, and yet it's not working. Only 40% of colon cancers diagnosed in the US are actually diagnosed at early stages. So if this is our plan in the United States, we're not doing very well. So why is it that colonoscopy is not conferring the benefit that we were hoping for United States of America? Well, when we think about colonoscopy, the really important point that Dr. Jones conceded is that it only works if it actually gets done. When we look at the state of Colorado, these are the individuals, the percentages across the country of folks that are up to date on colorectal cancer screening. And this is only 50-plus-year-olds. And for 50-plus-year-olds, we're at under 70%. It's even more depressing when we start to look at the data broken down by age. For 50 to 54-year-olds, less than 50% are up to date on colon cancer screening in America. There's even more concerning trends that we really have to be realistic and contend with. Many of us have encountered younger and younger patients being diagnosed with colon cancer, whether it's on our colonoscopy practices, our clinics, our friends, our family members that are succumbing to this disease at a much younger age than we would have expected. And though we don't have a lot of time to go into why this is happening, what's really scary is this phenomenon called a birth cohort effect. Essentially, what it means is that there's probably generational risk factors that are increasing risk. And as these generations, including myself, age, we're carrying these risks with us. Therefore, a 20-year-old that was born in the 1960s just actually has a significantly lower risk of getting colon cancer over their lifespan than a 20-year-old born in the 90s plus. So we see some concerning trends where in populations where we were starting to see positive trends because of screening, we're now seeing in 50 to 54-year-olds the rates going up over the recent years. Again, lots of different reasons for this, westernization of society, increase in risk factors like diabetes, obesity, perhaps other regional exposures, changes in our society, such as introduction of antibiotics in the food chain, industrialization of the food industry. Honestly, we could talk ad nauseum about what's actually causing this, but the bottom line is it's happening. And in response to this, our professional societies have decreased the age to start colorectal cancer screening from 50 to 45. The ACS, the American Cancer Society, was upfront in 2018 to make this recommendation. But essentially in 2021, every major professional organization came in line to recommend decreasing the age to start colorectal cancer screening at 45 instead of 50. Most importantly, the United States Preventive Services Task Force, which actually determines payer coverage. What does this actually mean for our practices? That means a bolus of 21 million adults between the ages of 45 and 49 that as of 2021 are immediately eligible for colorectal cancer screening. When we're thinking about things like colonoscopy, we really have to think about whether we actually have the bandwidth, the capacity to provide colonoscopy for all of these individuals. And as Dr. Jones said, if you live in Boulder and you have insurance, perhaps you do have the opportunity to choose colonoscopy as a test, but many Americans may not. Just in our system alone, that's 150,000 individuals in the UC Health system. Across the VA, curiously, we perform about 300,000 colonoscopies a year across the United States in the VA system. There's actually about just as many 45 to 49-year-olds in the VA system. So you can see how it's just not feasible to try to pretend we can offer colonoscopy to all of these individuals. So when we think about who's actually getting screening done and we factor in the 45 to 49-year-olds, that actually brings the state of Colorado down to 60%. And overall, 45 to 49 across the country is at about 20%. And unfortunately, the reality is that with all of these rates, we know that underrepresented minorities are much less likely to engage with and be adherent to colorectal cancer screening. And so we know there's disparities in access and disparities in outcomes because of this. So we know the rates are going up in young people. And because of this shared generational effect and the fact that all of us are sort of aging as we go, what's really scary is that 50 to 54-year-olds, the rate's going up. These are theoretically screen-eligible individuals. The rates should not be going up. Even scarier is in recent years for the older age groups where we thought we were really patting ourselves on the back. He showed you those incidence curves with colonoscopy going up, incidence going down. Those rates are actually flattening out over the last few years. And it's probably because our generation is aging and the consequences of going unscreened are much higher than they were before. So we really have to face the reality, okay? The reality is that a large proportion of our population is unscreened, and this disproportionately affects underrepresented minorities. And the consequences of going unscreened, of just rolling the dice and hoping you don't get colon cancer, is really a lot worse. Those odds are a lot worse now because of this birth cohort effect, these generational risk factors that are starting to accumulate as our millennial generation ages. So if colonoscopy isn't getting it done, what is the best colorectal cancer screening test? We know there's a bunch of different options. There's blood-based tests, there's stool-based tests, there's structural tests like colonoscopy, and we have all sorts of studies. And Dr. Jones showed you many of these studies that support the use of these variety of different tests, high-quality studies. And based on these studies, our professional organizations actually recommend a menu of options. And they recommend a shared decision between a patient and a medical provider to decide what the best option is. But the debate today is what's the best one for the US? I think when we think about the best one and sort of compare things side by side, Dr. Jones is right. If everyone gets a colonoscopy, the vast majority of colon cancers will be detected, and there will be probably a significant colorectal cancer prevention benefit from detection and removal of polyps. The problem is we can't just think in this silo, because it's a great test if you get it done, but what about colonoscopy as a modality for our society? We have to think about the cost. We have to think about how many people are actually going to get it done. So when you look at the adherence rates, and we'll debate these a little bit, only 50 to 60% of the colorectal cancer, the population is actually getting colonoscopy. So if we think about the United States and we think about the sort of expected prevalence of colorectal cancer, and these red folks unfortunately have colorectal cancer. If we think about colonoscopy and just how it's being done, how it's available and accessible and paid for in our country today, if 50 to 60% of individuals get colonoscopy, great. Those individuals confer the benefit from colorectal cancer prevention. But unfortunately, that leaves about half of the cancer diagnoses undiagnosed and likely to progress to late stages before they're actually found. On the other hand, if we go with a test like fecal immunochemical testing, it does have less sensitivity for cancer. So it'll pick up about 8 or 9 out of the 10 colon cancers out there. But many more people in the population will actually get it done. And so it actually performs a little bit better. But with that said, neither test really inspire a great ton of confidence on their own if our goal is to prevent or detect every colon cancer at an early curable stage. There's still a lot of cancer diagnoses that are floating around. So the argument that I want to make is that really the best approach is do as our societies recommend, and that is offer our patients and set up systems where there's a menu of options. So perhaps in a society where we do offer colonoscopy, and then if a patient declines colonoscopy, they're mailed a FIT exam, we get as many people screened as possible, we can do a much better job of detecting the colon cancers out there at early stages and curative stages. Still leaves some cancer undiagnosed out there. So Dr. Jones, I asked him to stay on the stage. So before he's like, oh, maybe we'll both go sit. I'm like, no, you have to stay on the stage because people need to see your facial expressions throughout this debate. But I can just see him chomping at the bit, sort of saying, I'm pretty skeptical. You're citing 80 to 90% adherence to stool tests. I showed you data that maybe that's the case on the first one they get. But we're talking about a test where a patient has to test their stool every year. And life races by us, right? And it's so hard to remember to do these things on an annual basis. 80 to 90%, that's way too ambitious. That's too generous of an adherence. Well, I think this is where we talk about where the field is going, okay? Historically, we've always thought of these structural tests like colonoscopy or CT colonography as being able to visualize the entire colon. Stool-based tests really designed to kind of detect cancers at a really early stage, maybe some really big precancer polyps that are shedding blood in the stool. And unfortunately, blood-based tests just haven't been a big part of the conversation because they really in the past have only detected really late-stage cancers where, as we talked about, that's not the point of cancer screening, right? We want to detect cancers early. But there's going to be a disruptive change in the field. It's coming. such that there's now going to be the emergence of blood-based tests that actually have really good sensitivity for early stage cancer. So let me just show you a little bit of what I mean here. These are tests that not just take advantage of trying to pick up circulating tumor DNA in the blood, but they really take advantage of what we call multiomics, meaning a lot of the different things and changes that cancer causes in your body and sort of sheds into your blood, whether it's immunogenic cells, whether it's other, types of methylation markers. But essentially, there are now multiple assays out there, simple blood tests that are under investigation and will be imminently available that can detect cancer at early stages. This was a study that was presented at a National GI meeting a few years ago that showed over 88 to 98% sensitivity for stage 1 and stage 2 disease. That is highly impressive. This is a study showing kind of side-by-side test characteristics of a blood-based test against stool-based tests, against sort of older generation blood-based tests. And you see a specificity of 94% with this blood-based test. And so you can imagine that as these technologies are going to become available, and mark my word, it will likely be within the coming year that blood-based tests will be available for routine average risk colorectal cancer screening. We have to think about how this can fit into the model. In this study where patients declined colonoscopy, 63% of patients were like, I don't want that. Only 3% said they don't want any colorectal cancer screening. The rest of them were totally open to getting a non-invasive test. And out of those who wanted a non-invasive test, 15% actually did want to play with their poop. And 83% decided that they would prefer a blood test. So that's really, really informative and helpful as we think about these options and add blood-based screening to our menu of options. And you can just practically think about the adherence to a blood-based test. Imagine going to your primary care doctor, and as they talk to you about the lipid panel they need to check, your thyroid function, your diabetes screening, they say, oh, well, also we should, potentially do some colon cancer screening. What are you into? Okay, not into colonoscopy. How about this blood test? You can see how this could get operationalized into clinical medicine fairly easily. So if we think about this model, and if we accept Dr. Jones's argument that there's no way all these green folks are actually going to do stool-based testing every year, perhaps we bring blood-based markers into the mix and change things up a little bit. And there might still be those 15 to 20% that are really committed to playing with their stool. But if we were able to add another contingent, another contender into this, the common screening test that we use, that could really go a far ways in finding all the colon cancers in our country at early and curable stages. So really, when we talk about the specific goal of colorectal cancer screening in the United States and the question that you've been asked to answer, and that is colonoscopy the best colorectal cancer screening test in the United States? I think the overwhelming answer has to be no, because the reality is, sure, it might be for you, but for the United States, the best test is the test that gets done. So with that, I'll give you the opportunity to vote. Put my vote in too.
So first of all, I tried to delete my Facebook like 40 times, but I was never able to for this exact reason. And I guess I have Mark Zuckerberg to thank for that. So I guess, my cross-examination question for you, Dr. Patel. In a system where, well, first of all, I guess I have two cross-examinations, which I know is cheating a little bit, but I didn't realize that our Facebook profiles were within the bounds of this. So I think I deserve to.
Guys, take the gloves off. Gloves off.
How many procedures do you feel like you do on a daily basis that aren't truly indicated, especially given the change in guidelines that have expanded our surveillance recommendations? And what do you think in the future will happen to those surveillance guidelines as we get more and more data on the protective benefit of polypectomy and colonoscopy in general?
Yeah, that's a great question. I think many of us can attest to the patients that show up that didn't need a colonoscopy. So you're absolutely right. There's capacity that we should ideally be able to open up, right? The patient at the VA who just had a colonoscopy at Kaiser 2 years ago and tells us that, but it just wasn't in the VA system. So the PCP ordered the colonoscopy. They're prepped. They're there. We oftentimes do it. Or, for the different studies that we're doing in kind of expanding surveillance intervals, perhaps the patients with those 1 to 2 tiny polyps, do they really need to come back in 5 to 7 years? You showed that high quality colonoscopy is protective for a very long time. You're right. I think we can continue to do better to open up capacity. But, I think that should be in addition to getting everyone screened, because the reality is all these 2-step tests, if we get every person in the United States a test, whether it's a colonoscopy or 2 steps up, that's not doing nothing for our volume and our jobs. We will continue to do colonoscopy. More and more of them will just be a follow-up of a 2-step test or a surveillance of a high-risk lesion, where we're not doing screening colonoscopy on average healthy young folks unless there's something that increases their risk.
All right. So I guess I have the rebuttal here. I'm going to cheat and phone a friend. First friend I'm going to phone is Michael Berhalter, who was the lead author on the Nordic trial. And coincidentally, I was listening to a podcast earlier this week in which he was interviewed. And guess what colorectal cancer screening test he chose for himself?
This is Michael Berhalter.
Yeah.
Knowing him, I suspect he would have chosen a FIT test, but maybe I'm wrong.
No, he chose colonoscopy.
Colonoscopy. Okay.
And, we've almost made it through an entire medical conference, and no one has brought up ChatGPT yet. So I thought, as part of my rebuttal, I would ask ChatGPT what the best colorectal cancer screening test is in the United States. And I actually already did this, and it said colonoscopy. But all jokes aside, I agree that we need to offer a menu for our patients, but we need to be honest when we offer that menu, and we need to delve into the test characteristics of the tests that we're offering them. And if you tell your patients that there's, a 15 to 20% risk that their screening test is going to miss a cancer, more of them might start to choose a test that's much, much better. And I'm not sure we're all doing that. The other point I would make is that in a system where we are, steering patients towards any screening test, what inevitably is going to happen is that patients, like you mentioned, who are more vulnerable and perhaps more likely to be high risk for colorectal cancer, are going to be more likely to be offered stool-based testing, the inferior test, and we're going to just expound on existing inequalities within our healthcare system. So yes, it's better to get people screened than for them not to be screened. But I think you can't argue that colonoscopy is the best test. I think you can't argue that we have more capacity than we currently have. And I also think if we see what happens when we get more and more data, we're going to realize that colonoscopy is more protective than we even realized. We're going to have the opportunity to perhaps do what they do in Poland, which is do one lifetime screening colonoscopy and say that is incredibly protective for up to 2 decades if you have no polyps. And if you have a few polyps, your risk is probably no greater than if you have no polyps. And I think there's other data that shows that we don't really define advanced adenomas well, and we're probably way too conservative. And so we're probably bringing people way back and way over using colonoscopy. But I think that the point remains that if we're giving patients a menu of options, we have to be honest about the test characteristics. Colonoscopy is always going to be the best test. If they don't want it, that's fine. But then you have to be willing to guide them to colonoscopy if their other screening test is positive. And so if they're not doing a colonoscopy up front for whatever reason, that already suggests that it's going to be hard to then convince them to do the colonoscopy, even if they have a positive test. And that is, I think, supported by, the literature where we use FIT in patients because they don't want to get a colonoscopy. They're more likely to be, Hispanic, underserved, minoritized patients. And then we have a really hard time getting to colonoscopy when they have a positive FIT. And that's just because, we don't put in the effort up front to build the infrastructure necessarily to get them to colonoscopy. And if we're going to do that effort anyways, we should really be offering those patients colonoscopy, I think, in the first place. If they don't want it, that's fine.
Swati?
I actually don't refute anything that you say about the value of colonoscopy. It's amazing, right? When we see that advanced adenoma, we lop it off. We know that that patient's walking away with a cancer prevented. So again, when we vote, it's important to vote on the question that's being asked. It's not, is colonoscopy a good test? Is colonoscopy the test that you're going to do when you turn 45 or that you're going to recommend to your friends, family members, or even your patients? The question is, what's the best approach, the best test for the United States? And we can either take the approach of sticking our heads in the sand, crossing our fingers that colonoscopy capacity, physician behavior of overdoing colonoscopy in certain populations will just get better. And it'll open up all this colonoscopy capacity, and we will try to be able to deploy that in a systematic fashion to our entire population. Or for the ones who are willing to come to colonoscopy, keep those doors wide open. But for all those people where a colonoscopy is ordered, they don't show up. Another colonoscopy is ordered, they don't show up. A third colonoscopy is ordered, they don't show up. There are many out there that really are just getting no screening whatsoever. And I agree with you. The resources to get those positive screens navigated to a colonoscopy need to be dedicated to completing the process of screening with the finishing colonoscopy. But the reality is that vast majority of those folks are just not getting anything at all. Some of it might be because they have a preference for a non-invasive procedure and may not complete colonoscopy, but the vast majority are because they just really haven't thought about it or haven't been offered it or haven't advocated for themselves. So I think we need to think about a programmatic approach to colorectal cancer screening and a sequential approach, meaning perhaps you're offered a colonoscopy, but if the colonoscopy is not completed, for instance, in the Kaiser system, they just mail folks a stool-based test. And that really is the safety net to capture everyone. And as we have more and more easier two-step tests that will be emerging over the coming years, this is the model that we have to think. So I think that, colonoscopy is a phenomenal test. I will never argue against that. That's what I do in my clinical work. But the reality is you've been asked to vote on whether colonoscopy is the end-all be-all for colorectal cancer screening in the United States. And for that, I hope I've convinced you that we need to think broader, that it's any test, including colonoscopy, especially for the folks that are just never going to get anything otherwise.
Can we have the audience ask questions? I'm going to bring the mic back, and if you could help me, Lindsay.
So I absolutely see both vantage points. I would say that the question is lacking in that it should be, are colonoscopies the best test for colorectal screening today? Because the flaw in Dr. Patel's logic is blood tests are not available at the moment. And as somebody who tried to screen per poop sample in the mail, at age 50, it got lost and it never reached where it was supposed to go. So the only real way I was screened for colorectal cancer was when I had my colonoscopy at university and then got a job there. So in that way, I think today, though both of your arguments are excellent, at this moment in time, colonoscopy is kind of the best test for it due to the human factor of mailing in the tests and the inavailability of blood tests at this moment. Or do you have an inside track that I am unaware of, Dr. Patel?
No, I was just going to tell you that the check that Dr. Jones has for you, you can pick up on your way out. No, yeah, he's going to just swirl around and find your name. I acknowledge, these two-step tests are challenging to not only complete the test, to follow all the instructions, send it in before it's an expired sample. And then, you didn't really even talk about sort of the challenges that patients have in navigating to a timely colonoscopy after that test. And then you got to do it all next year. I acknowledge it's challenging. And if colonoscopy is accessible and available to you, go get it. Go get it. There are the folks who don't even know conferences like this exist. And for that population of folks that just has much more going on, I think we do have to at least try to get some type of screening test done for them.
So I have a question. Is there any data on how many people develop colon cancer from after colonoscopy versus after other modalities?
Well, there's data on kind of the, I guess, what percentages of cancer are within a screening program and what with our, and we know that, I mean, there's interval colorectal cancer, which is just any cancer that's not within the recommended surveillance interval. There's post colonoscopy colorectal cancer, and probably about 10% ish is the data I've seen. Swati, you can disagree with me, but that of cancers of colon cancer are fit within those frameworks. So it's a significant minority. I'm actually not aware of data that, you know, we know the test characteristics of stool-based testing don't perform as well. So it's, you know, you're more likely to miss a cancer with stool-based testing. I don't know of data that specifically says the proportion of cancers that are diagnosed in people who've only done FIT-based screening or multi-target stool DNA.
So the stool-based tests, and again, this goes back to what the point of screening tests are in our country, right? They're to decrease death from the disease and ideally decrease cost burden long-term. So with that in mind, you know, things like mammograms are designed to detect cancers at early stages where patients can get surgical resection and then go on to live a long, healthy life. So colorectal cancer is unique because, you know, not only can we do that, right? A stage 1 cancer, surgical resection, that patient has a 95+% chance of never having to deal with cancer-related problems of their colon again. But with colorectal cancer, we know that we can find these polyps, and there's this sort of concept of trying to potentially prevent disease, which is reasonable. I think, you know, for your question of, you know, what's the detection rates, you know, for colonoscopy versus a stool-based test, up front, we will admit to you that if you have 10 patients with colon cancer and you administer a stool-based test today, you will pick up 8 to 9 out of those. And one cancer patient sitting right in front of you, the stool-based test won't pick up. With colonoscopy, that's very, very unlikely. Now, as we all know, as everyone who's been in a procedure room, colonoscopy is a very operator-dependent test, bowel prep-dependent test. And when we look back, as Dr. Jones said, of all colon cancers, about 10% have had theoretically a colonoscopy within the last few years. So there's lots of different reasons for that. We don't have to, you know, argue or debate that. I think both Dr. Jones and I can agree that a colonoscopy should only be done if it's done by a high quality, high adenoma detecting endoscopist, good bowel prep, complete to cecum. I think those things aren't necessarily under debate, but they're just designed to detect different things. And so I don't think stool-based testing is really even promoted as a cancer prevention test necessarily, but it's to prevent those deaths across the country that are happening from people showing up with stage 3, stage 4 disease because they only come when they have symptoms.
Swati, just briefly, I know you have obviously been a big part of writing some of these guidelines and talking with experts around the country and the world for that matter. You were at the White House earlier this year and talking about colorectal cancer screening. So could you comment just briefly on how reflective the conversation that you and Blake had today, how much that reflects the conversation that happens when guidelines are written? And as a second part to that question, when the guidelines are written, how is the topic of bias approached? You know, we may be biased towards colonoscopy because that's what we've been trained in. So if you don't mind commenting on that.
Yeah, and I think this is really, really important because somehow, you know, when we go through our training and we think about guidelines, we think of them as sort of these, you know, very altruistic, unbiased sort of sources of information to guide our clinical practice. But each guideline body, you know, comes from their kind of vantage point and has the societies that they represent and the stakeholders that they have. So, you know, for instance, the Multi-Society Task Force is representative of the American Gastroenterological Association, the American Society for Gastrointestinal Endoscopy, and the American College of Gastroenterology, right? So all GI organizations. And interestingly, when we wrote the colon cancer screening guidelines, deviating from every other group, the MSTF recommends a tiered approach to colorectal cancer screening, where tier 1 tests are colonoscopy, and FIT-based testing. And then tier 2 is things like CT colonography, FIT fecal DNA, et cetera. But when we look at test characteristics, we even look at sort of the studies available, there's really not a ton to justify that tiered recommendation. There's certainly very strong evidence for FOBT, but to put things that have data also, certainly similar to colonoscopy data in the tier 2 group, it's sort of begs to question, why was that done? And so I think that's where the GI societies come from their own perspective, right? We're all colonoscopists, so that's certainly part of it. But the other part of it was that the MSTF really felt strongly to give clinicians something practically useful, some practical guidelines, like, look, offer your patients colonoscopy or FIT, and if they turn that down, and if you work in a place that does good quality CT colonography, that's a consideration. And then finally, if they can't get through all those things, you could do a capsule colonoscopy. They all look at the same data. So on the other hand, organizations like the National Comprehensive Cancer Network, that represents National Cancer Institute designated centers across the country, sort of a more oncology bent to it, really just says we should offer a menu of screening options and doesn't really put things in tiers. So Avash, there certainly is, the vantage point that some of these guideline bodies come at some of these questions. And I think that's something that we have to consider in this room too, right? Because this is a GI conference. All of us in some way have a connection to GI, and our bias, including mine, is towards colonoscopy. But for folks around the country and certainly internationally, there is a lot more perspective on population-based approach to screening and just trying to get a screening test done in everyone. If colonoscopy is part of it, great, but there are many other tests that we also recommend.
All right, perfect. Well, we're out of time. Any of you that want to spend the rest of the day and tomorrow talking about colon cancer screening, Dr. Patel will be here, and I'm sure she'd be very happy to let you know her opinion about it. We need to vote one last time on our question. So could I have it up? Excellent. I proclaim the debate a tie. We can all go have a drink. We have a couple of announcements from our course directors for you all. Thank you very much.
All right. Yeah.
Yeah, we'll do that. All right. So this just a few quick closing remarks. We're almost done. First thing, we want to thank all our speakers so much. Obviously, this would not be possible without you, Dr. Ahmad, Dr. Mugudyala, Dr. Whelan, Dr. Ahmad, Dr. Edmundovitz, Dr. Patel, Dr. Reddy, Dr. Rice, Dr. Pakala, and Andy Dwyer. Thank you so much.
Never too early to start looking ahead, but a year, the 11th Rocky Mountain Highlights Conference will be approximately a year from now. So look forward to that. But we're hoping for free conference registration again. And of course, thanks for being involved this year.
And then these are just a few more conferences that we have coming up within the division and sections. So this is another save the date. Actually, I should probably let Dr. Colliver talk about this one because it's his conference.
So this is an ongoing webinar series on topics related to the chronic liver disease and liver transplantation management. So we'll be doing 4 or 5 webinars per year. This is also free CME and nursing contact hours as well. So our next talk is August 23rd. My colleague Whitney Jackson will be talking about the role of living donor liver transplant. You can see there's going to be one in September, one in November as well. And then we'll have a whole new set of webinars for next year as well. I will also mention that the videos for all these webinars are recorded and saved on the website as well.
And yeah, another save the date, the 18th Rocky Mountain Interventional Endoscopy course will be next April. Friday and Saturday, free registration again. And we often have international attendees, which is always excited. A lot more live endoscopy than we have in this course. And then one last time, we want to thank all our supporters. So Olympus, Castle Biosciences, Exelixis, Takeda Pharmaceutical, Tivio, Cook Medical, Janssen, Takeda Pharmaceutical Company, Gatex, AbbVie, Inc., Happen Pharmacology, Irby, Fujifilm, Microtech, Endoscopy, Medtronic, Ovesco, Endoscopy, AbbVie, Digestive, Bristol Myers Squibb, Gilead, Intercept, Olympus, Sanofi, and Steris.
We'll be sending out feedback forms, and really don't hesitate to give us feedback before you leave today. In addition to filling out the feedback form, we used the feedback form from last year to make some adjustments to this year, and we hope to do the same for next year's conference. Now what you've been waiting for. Yep.
So looks like odds are pretty good. Get 10 people win.
Me to do it?
Sure.
All right, we're doing this Price is Right style, so y'all got to come on down. Danny Cooper. I swear I mixed these up. I am not doing the VA thing again. Mabel Martinez. Yeah. Go to her. I'm going slow. I got it. You want to pick one out? I don't get it. You should unpress her ID again.
Kelly Hosey.
Yeah.
Karen Greenberg.
Yeah, we are. Run, Matthew. Janet Hank. Hold on, how many is that? 1, 2, 3, 4, 5. We still got 5 to go.
Yeah.
Mike Molman. Yeah.
Sarah Christmas.
How many is that? Rebecca Bontuana. I don't know if I got that right. Bontawa. Yeah. I butchered that. I'm sorry. Thank you for being here. 3, 4, 5, 7, 8, 9, and 1.
Betty Martinez. Uh-oh.
Uh-oh.
Not here, so it doesn't count.
Doesn't count.
No.
Don't tell Eddie.
Don Coleman. Yay, Don.
All right, your last one.
Yeah.
Oh.
The 10th and final gift card goes to Megan Farley.
Yay, Megan!
It's 10, right?
4, 5, 6, 7, 8, 9, 10 more.
Okay, thanks. So congrats to the winners. Blake and I also want to take a moment to acknowledge and thank the course organizers once again. So Matthew, Lindsay, and Christy, if you don't mind coming up here as well so that everybody can see you. They have their. We got you guys a gift bag as well for each of you. Lindsay's. Yes, of course. Of course. And yeah. Yeah, and all we really could not have done this conference without the three of you. You guys made our jobs extremely easy over the last year, and we're deeply appreciative. So thank you.
All right, and just a reminder, so you get credit for being here. These are the ways to get it. There's a link on the website for the conference. There's the QR code to check in. And then we do have the course survey and everything like that. You can always contact Lindsay if you need any help with anything.
So this is just a repeat of some of the slides from earlier. 5.75 AMA credits. All of this information is available on the website as well, including the ABM or maintenance of certification points.
Yeah, one final disclosure list. Please don't forget to fill out the survey. We always like to hear feedback for next year. And then again, just more information about getting credit. Do everything before August 13th or 14th. All right. More disclosures. Here's that QR code for nurses. It's at the front desk too, in case if you didn't get it. We can just leave this slide up here because it's the last one. But thank you guys so much for coming. It's a great conference. All thanks to you guys being here. Thanks to our speakers and thanks to Lindsay, Christy, and Matt.
Thanks, guys.